Hello viewers, welcome to today's lecture. Today we are going to discuss about Addison disease. Case scenario. Alif, 10-year-old boy who presented to the emergency department with the history of weakness, fatigue and dizziness for the past 2 weeks. The patient reported a loss of appetite and a 3 kg weight loss during this time. He had a recent history of episodic vomiting and diarrhea. During each episode, he vomits 5 to 6 times per day, which was non-projectile. He had no significant medical history, allergies, or recent travel history. On examination, the patient was found to be dehydrated and hypotensive. He had a low-grade fever and tachycardia. Laboratory test reveals hyponatremia, hyperkalemia, with random blood sugar 3.2 millimole per liter and serum cortisol report was pending. So at this point, what is your clinical diagnosis? It will be a case of Addison disease. Now mention the points in favor of clinical diagnosis from above case scenario. The patient has weakness, fatigue, dizziness, loss of appetite and weight loss. Those symptoms can be indicate a chronic illness such as Addison disease. Recent history of vomiting and diarrhea. Those symptoms may be related to an underlying condition causing adrenal insufficiency. No significant medical history, allergies or travel history. These rule out the other potential cause of patient symptoms such as infection or recent medication use. Physical examination. Dehydration. This finding is consistent with chronic adrenal insufficiency. Hypotension. Low blood pressure is a common finding in Addison disease due to lack of aldosterone. Low grade fever. This may be indicative of an underlying infection or autoimmune process. Tachycardia. Increased heart rate that can occur due to electrolyte imbalance and dehydration. Serum electrolyte abnormalities, hyponatremia and hyperkalemia are commonly found in Addison disease due to lack of aldosterone. Pending serum cortisol report. The serum cortisol level in a critical is, is a critical diagnostic test in Addison disease, has low levels indicating of adrenal insufficiency. Now what will be the other clinical features that support the diagnosis? That will be skin hyperpigmentation. Addison disease can cause skin hyperpigmentation, especially in sun-exposed area due to increased melanin production stimulated by elevated level of adrenocorticotropic hormone. Family history. Family history of autoimmune disorder or Addison disease may be increased in the likelihood of a diagnosis. Previous surgery or infection involving adrenal gland may have damaged the gland and leading to adrenal insufficiency. Physical examination. Mucous membrane hyperpigmentation. Hyperpigmentation in oral mucosa, gum and lips may be observed in Addison disease. Orthostatic hypotension, a drop of blood pressure upon standing, may be observed in Addison disease due to decreased fluid volume and lack of aldosterone. Abdominal examination, tenderness or the sign of inflammation in the abdominal area may suggest underlying autoimmune process such as autoimmune adrenalitis. Sign of autoimmune disease. Other signs of autoimmune disease such as joint pain, muscle weakness or skin rash may suggest an underlying autoimmune process leading to adrenal insufficiency. Write the common differential diagnosis with the point in favor and against differential diagnosis. So the first differential diagnosis will be gastrointestinal disorder such as inflammatory bowel disease or celiac disease. The points in favors are weight loss, abdominal pain, diarrhea are the common symptom in both conditions. Hyperpigmentation and electrolyte abnormalities are typically not seen in gastrointestinal disorder. Hypothyroidism, fatigue and weight gain are the common symptoms in both Addison disease and hypothyroidism. Hyperpigmentation and electrolyte abnormalities are not typically seen in hypothyroidism. Chronic fatigue syndrome. Fatigue is a common symptom in both Addison disease and chronic fatigue syndrome, and chronic fatigue syndrome typically does not occur any hyperpigmentation or electrolyte abnormalities or low blood pressure. Now, right, Now, what is the pathogenesis of the disease? Addison's disease is also known as primary adrenal insufficiency, is a condition that occurs when the adrenal gland fails to produce enough cortisol and aldosterone hormone. Those hormones are essential for maintaining the body's salt and water balance, regulating blood sugar levels, and response to stress. There are several underlying causes of Addison disease, but the most common cause is an autoimmune reaction against the adrenal cortex. In this process, the immune system mistakenly identifies the adrenal cortex as a foreign invader and attacks and destroys the adrenal gland tissue. Autoimmune response can occur alone or in association with autoimmune disease such as Hashimoto's thyroiditis or type 1 diabetes mellitus. The other cause of Addison disease may include infections such as tuberculosis, fungal infection, and the viral infection such as cytomegalovirus and HIV, which can infect and damage adrenal glands. Uh, Additionally, the certain medication, surgery, and radiation therapy to the adrenal glands and metastatic cancer that spread to the adrenal gland can also cause adrenal insufficiency. Right, relevant investigations with interpretation of findings. First, we run some blood tests that will be serum cortisol, aldosterone, and ACTH level. In Addison's disease, the level of cortisol, aldosterone are typically low, while the level of ACTH are elevated. Serum electrolyte to check the imbalances, hyponatremia or hypokalemia. Random blood glucose to see hypoglycemia. This can associated with Addison disease. ACTH stimulation test in healthy individual, plasma cortisol is greater than 500 nanomole per liter. The level of cortisol should increase after receiving an injection of synthetic ACTH. In Addison disease, the cortisol level will not increase significantly in response to the ACTH stimulation. Imaging studies such as CT scan or MRI may be used to check the size and shape of adrenal glands, and sometimes MRI to find hypothalamic or pituitary cause, or to search metastatic carcinoma of Addison's disease. Antibody testing. In case of primary Addison's disease, autoimmune antibodies may be present, sporadic polyglandular syndrome. Now write the outline of management, including general management and counseling, supportive management, specific treatment, management of complication, and follow-up of the patient. First of all, general management and including counseling, education and counseling the patients of Addison's disease with the signs and symptom of adrenal crisis and instructed how to self-administer emergency injection of hydrocortisone. They should also be counseled on the importance of lifelong hormone replacement therapy and need for regular follow-up. Supportive management, diet and lifestyle modification. Patients with Addison disease may need to increase their salt intake to help maintain appropriate sodium levels. They should also avoid activities that can cause dehydration or stress, which can trigger an adrenal crisis. Specific treatment, hormone replacement therapy. This mainstay of treatment of Addison's disease is a hormone replacement therapy, which involves daily oral or injectable corticosteroids or to replace the deficient hormone and maintain the normal level of cortisol and aldosterone. Management of complication. Adrenal crisis. Adrenal crisis is a life-threatening emergency that require immediate treatment with intravenous hydrocortisone and supportive care such as fluid or electrolyte replacement. Hypoglycemia that will be corrected by oral or IV replacement of glucose. Follow-up. Patient with Addison disease should have regular follow-up provided to monitor hormone level, adjust diagnosis, and evaluate the potential complication. Patient with autoimmune disease, Addison's disease, may be at increased risk of other autoimmune disease, should be monitored for those conditions. Write the prognosis of the disease. The prognosis of Addison disease is generally good with appropriate treatment and management. Hormone replacement therapy with glucocorticoids and mineralocorticoids can effectively control the symptoms and prevent complications such as adrenal crisis. With proper treatment, most individuals with Addison's disease are able to lead normal and healthy lives. With proper care, the most patients with Addison's disease can expect to lead a full and healthy life. Now, the gist points are: Addison disease is a condition in which the adrenal gland fail to produce enough cortisol and aldosterone hormones. The most common cause Addison disease is an autoimmune reaction against the adrenal cortex. The symptoms of Addison disease include fatigue, weakness, weight loss, low blood pressure, salt craving, and electrolyte imbalance. The diagnosis of Addison disease is typically confirmed through blood tests to measure cortisol level and ACTH stimulation tests to assess the adrenal gland function. Treatment of Addison disease involves lifelong hormone replacement therapy with oral corticosteroids such as hydrocortisone or prednisolone and mineralocorticoids such as fludrocortisone and to replace the missing aldosterone. Thank you. Thanks for watching and keep subscribe the channel to get more videos. Thank you and thank you for watching.